So this talk is on olaparib for maintenance strategy for stage 4 pancreatic tumors. Epidemiology wise, about 5 lakh new pancreatic cancer patients are diagnosed every year. And if you see the percentage wise, it is about 2 to 2.5% comprising of all cancers. So it's not that much, but the problem is the mortality. So if you see all comers pancreatic tumors, the 1 year survival is just about 20 to 30%, which just tells you that this is one of the worst cancers mankind has seen, and virtually single digit numbers for 5 years and 10 years. So definitely there is a lot of unmet need in this, whether we say better surgical techniques, better neoadjuvant chemotherapy, but we need more strategies to deal with this cancer. And the active drugs for this cancer, we all know, are 5-FU, gemcitabine, and the last few are gem, nab-paclitaxel, and FOLFIRINOX. Even the best treatment regimen with this for this cancer gives about 5 to 6 months of first-line PFS, which just tells you that definitely we need something more. Now, this was an interesting paper, and as always, as medical oncologists, we go in the detail for the genetic alterations. And this was a paper from Foundation, and it said about 1 in 4 patients, about 25% of patients, have some DNA mismatch repair pathway alterations. Apart from BRCA, we have ARID1, ATM, and we have CHEK2 and PALB2s. And we know from the lessons learned by ovarian cancer that if these alterations are targeted by PARP inhibitors, they can give a survival advantage. Retrospectively seeing, if you have a BRCA mutation or BRCA alteration, if these patients are given platinum-based treatment, their survival is also improved, as you can see, 1.8 years compared to just less than a year. And even that applies same for any HRR alteration, not only BRCA, with the picture showing 2.3 years versus less than a year. So this was the rationale of conducting a study of olaparib in first-line maintenance setting with stage 4 germline BRCA mutant pancreatic cancer. This was a global study where patients got 4 months at least of induction chemotherapy. And if the patient still had a response or a stable disease, they were randomized to either get olaparib or nothing. Now, although this was a global study and 12 countries participated, the first 4 countries, means the US, France, Germany, and Israel, enrolled about 2/3 of patients. So not really a global study, 2/3 patients coming from just these 4 countries. But anyways, this is a very difficult to accrue study, and the researchers must be congratulated for that. Now, it took 4 years to enroll 150 patients. That means just 3 patients a month in the entire world, which again tells you that this is a very difficult to accrue study. Now, the baseline characteristics were well matched. As you can see, the median age was younger. What we would see in pancreatic tumors elder than 60, 65, the median age was 57. What is important to see is the upper end of the age. So we are often told that we should not be testing if patients are older, but no, even patients who are 70 or 80 may have a BRCA mutation, germline BRCA mutation. So nowadays the guideline says any metastatic pancreatic cancer, we should be testing for BRCA germline alteration. Although slight discrepancy in the liver metastasis in the group, like favoring the olaparib rather than placebo, but I don't think so that would make much difference in the results. As discussed before, about 80 to 85% of patients did get 4 months of FOLFIRINOX, and rest of them got a gemcitabine-based treatment. And this was the primary endpoint. So after 4 months of treatment, if you give them olaparib, the median progression-free survival was doubled, 7.4 months as compared to 3.8 months. So that is a hazard ratio of 0.53. Also, we can say as 47% risk reduction in risk of progression or death. So such a large survival advantage or progression-free survival advantage in pancreatic world we are seeing for the first time. What was important is at every given point, in 6 months, 12 months, 18 months, or 24 months, the olaparib seemed to show benefit. So that means if you're responding on olaparib, you continue to show response on olaparib. And it is not a short-lived response. It's just like immunotherapy, which can keep on going. So if you see a cartoon where you add maintenance to first line, of course, your 1 year overall survival would be increased. Now, this study was not powered to show the difference between the different subgroups, and hence you see the forest plot all over the places. What was important is about 15% of patients did get PARP inhibitor on progression from the placebo arm. Although I would have liked this number to be higher, uh, but nevertheless, only 15% of patients got PARP inhibitor in any subsequent lines in placebo. So although we can say there was a crossover allowed, but it was not up to the mark. Now, this was what was a most important and a most selling point based on which the FDA approved this drug for first line maintenance is the response rates. If you see complete responses, we hardly ever see complete responses in pancreatic tumors and partial responses. So around 23% of patients had actually tumor shrinkage based on the RECIST response, which is nearly as what we would get with FOLFIRINOX, 30%, 35%. So a single oral pill can do this much, which is very impressive. And the disease control rate was also much better. And as important, what I said is, if you had a response, your response was in years and not in months. As you can see, the median duration of response is 2 years. So that means if these 23% of patients who had a response, they went long term. Now, the overall survival was also part of the analysis. Although it was not powered to answer this, there was no difference between overall survival numerically. Although at 3 years, the curve started separating, again suggesting that olaparib, people who responded to olaparib, they were more likely to be without disease or with control of disease as long as possible. And this is the long-term outcomes of olaparib. Like at 2 years, right? In pancreatic cancer, we don't use years in talking, we use months. And at 2 years, these many patients were still on olaparib. If you see the CR rates, 15% of patients had CR just on olaparib. That is very, very impressive. Now, whenever we use a maintenance strategy, an important component is whether the quality of life was decremented. And in the overall, in the HRQOL analysis, what was shown that olaparib did not harm the patients as compared to placebo. And the toxicity, we all have used olaparib for breast cancer and ovarian cancer. The only real meaningful toxicity is anemia. And we are, as a medical oncologist, we are comfortable managing this side effect. So in conclusion, the POLO regimen has changed the paradigm for treatment of pancreatic cancer. It's a first biomarker-driven therapy for stage 4 pancreatic tumors. And at 3 years, about 17% of patients are still on olaparib, which is very impressive. And 21% of patients in olaparib arm remained free of subsequent cancer treatment. Global quality of life was also not impaired, and it was maintained throughout. And I think so the most important take home is it was well tolerated, and it has to be a new treatment option for stage 4 pancreatic tumors who have undergone induction chemotherapy as a maintenance strategy. Thank you.